Good evening and welcome to our educational webinar on Lapiplasty 3D bunion correction. We appreciate you joining us tonight. My name is Kara Lyons. I'm Director of Patient Outreach for Treace Medical Concepts. Treace is the company who patented the Lapiplasty procedure and manufactures its instrumentation and implants. Our goal here tonight is to provide you with quality information because we know that making a surgical decision is a decision that isn't taken lightly. I'll get a couple of our housekeeping items out of the way so we can get right into the presentation by our surgeon speaker tonight, by Dr. Jeffrey McAlister from Phoenix, Arizona. First of all, if you're listening on the webinar, you've entered the webinar in mute mode, but you can still ask questions throughout by clicking on the question tab in your control bar and typing them in. We'll be answering questions sprinkled throughout the presentation and at the end of the presentation. And if you're a note taker or inadvertently missed something, we'll be offering this presentation as an archive link to refer back to. So look for that as a follow-up item from us in just a couple of days. Lastly, I know you're going to enjoy our surgeon speaker tonight, Dr. Jeffrey McAlister, but if you are attending outside the Phoenix metropolitan area, you can also find locally trained Lapiplasty surgeons to consult with in your own area by visiting our patient website, www.alignmytoe.com. There's a prominent Find a Doctor button at the top of the homepage, and you can search for local doctors by zip code. With all that out of the way, I'd like to introduce tonight's surgeon speaker, Dr. Jeffrey McAlister. Dr. McAlister is a paid consultant of Treace and has a long list of credentials. His qualifications and experience are extensive, and his practice is a Lapiplasty Center of Excellence. Dr. McAlister is board certified in foot and ankle surgery. He attended the University of Iowa and Temple University's Podiatric School of Medicine. He is one of only a few podiatric surgeons in the U.S. who has completed a 12-month surgical fellowship at the prestigious Orthopedic Foot and Ankle Center in Columbus, Ohio. Dr. McAlister is a national speaker and a peer educator, and he is a member of the American College of Foot and Ankle Surgeons. We appreciate Dr. McAlister volunteering his time tonight. I'll return to moderate a question and answer segment at the end, but now I'll give it to Dr. McAlister.
Thank you, Kara. Thanks for having me, guys, and welcome to everybody. Arms up, waving to everybody in the audience. I just want to give a thank you to Treace Medical Concepts for having me and allowing me to introducing not only myself, but also this amazing system. And let's just get right into it. So tonight we want to go over the Lapiplasty system. We want to go over why a bunion occurs, how it occurs, and what are some treatment options. But first, a quick background. So this is an FDA-cleared device. It's been FDA cleared since 2015. This is not an investigational device. This is something that we've studied, we've been using, and the research shows that it's working. It's a patented procedure. This has been manufactured by Treace Medical Concepts for several years now, and it does require advanced training. Not all your standard foot and ankle surgeons are going to be able to perform this procedure. They have to read the textbook, if you will. Thousands of surgeons have been trained, though, and patients have been treated with great success. You can find your doctor, as Kara stated, at alignmytoe.com/doctor. So the important thing to know is that this procedure is a covered procedure by most insurances and Medicare. This is obviously something that you need to check with your provider and look at your insurance options from that standpoint. So as with any medical treatment, this is an important slide to read, individual results may vary. We're talking about surgery here. There's no specific guarantee. There are potential risks, and recovery does take time, and that's discussed in the office. It should be discussed every time that we're discussing preoperative plan and surgical outcomes. And some of these potential risks are really of any surgery, but as it relates to Lapiplasty include infection, discomfort from the presence of the implant, loosening of the implant, so if the implant becomes loose if something is going wrong. And what could go wrong is a loss of correction with a non-union or a malunion. Well, what's that, doc? Well, a non-union or a malunion, think of it as if we're trying to glue two pieces of bone together and stabilize them with plates and screws, if the bones don't glue together or weld together for whatever reason, whether the person is immunodeficient or if the bones just do not want to grow together over time, we call that a non-union, where they don't grow together, or a malunion, where they grow together and in an off position. So if these things occur, then typically, we'll need to go back in and do additional treatments, but that is not common. And only a surgeon can tell that if a Lapiplasty procedure is right for you. This is not something you're going to find on the internet that you can plug in your position of your toe and spit out the procedure. This is something that needs to be documented well by a surgeon trained and in the office. So all of that out of the way, let's kind of dive into what a bunion is and how it affects a person's quality of life. And that's kind of what the nuts and the bolts of this is bunions. So bunions are also called hallux valgus. And one of the most common questions I get is, do I have a bunion? And, I've been wanting to do a research study recently, looking at what a patient considers a bunion. A patient may consider a bunion a bump. A patient may consider a bunion the rotation of the toe. And all these things do come into play. But what we really need to think about is how this bunion occurs over time. And we can see that here through the progression of kind of mild, moderate, severe. And you can see from left to right on your screen, a mild bunion deformity is a bump right underneath the great toe, oftentimes painful in shoes. We can see that big toe as the progression of the problem continues. And that's the important thing to note, is that this problem is there's a natural history to this problem. The bump gets bigger is the kind of title of the presentation. And so it usually starts as in our pediatric patients as a mild deformity, and over time does develop into a moderate and more severe deformity. And look at that second toe on the far right image there. You can see the second toe is pretty much up in the air. It has a large callus or blister on the top of the second toe rubbing on the shoe. And that's usually what drives a person in. It's not the looks. It's not the really the looks or appearance of it. It's the second toe or the bump on the side of the foot that does bring a patient in. The important thing to know from a mechanical standpoint is, and what you do start to think about this, once you start to have pain in your big toe, you do heed more attention to your big toe and your feet in general, but your entire body weight goes through your big toe with each step. So as that engine or the big toe mechanism starts to be off kilter, which we'll show you in a minute, that bunion can hurt a lot. And so it's important to know the mechanics of it. Typically, we'll see patients in the office with pain, swelling, pressure and numbness from the side of the great toe in a shoe. And so that typically is what brings patients in. And really, it's the shoes that crowd the foot and allow it to be in a compressed area, and is very painful. So what are the causes really? So what is often misunderstood is bunions are a growth. Bunions are and bunions typically will continue to grow over time. So what we're starting to understand is that bunions have a genetic predisposition. There's a biomechanical imbalance, so you can get it from your mom and dad, and you can have it because you have flat feet or high arched feet. So there are multiple causes, but these are the big ones. The third big one is the constrained footwear. So I typically tell patients, you got it from your mom or dad. You either have it because you have a flat foot or because over time your shoe gear has worsened it. And often it's related to what type of occupation or job we have. So if we're required to wear high-heeled shoes or ill-fitting shoes without a wide toe box, or if we're a dancer or an athlete, for instance, typically you're going to have some type of big toe arthritis / bunion deformity that can cause discomfort and pain in shoe gears. And this is what I'm talking about, this guy. These do keep me in business, but they are good looking for sure, but they do cause problems over time. And that's obviously because you can see that the crowding of the big toe does cause a constraint on a big toe joint and even the small toe, but it's just not a normal position for a toe and the toes. And so that the mechanics are thrown off. And that's usually pretty clear when patients come in and talk about bunion deformities, but I think it needs to be brought back home that if we are going to correct any deformity, that we need to be wearing the right shoes, and that's really important. Some common questions that we're seeing at this point are, when am I a good candidate to have my bunion treated? I have a son with a bunion. I have a bunion. My grandma had a bunion. My mom had a bunion. I know this is genetic, and my son has a bunion. Is it time for him to get his bunion? And those are common questions that we do get in the office and that I answer every day. Typically, the answer is if it's bothering you, and if it bothers you every day and causes pain. So we're not all about operating on people that don't have pain, but if the deformity is causing pain, swelling, numbness, or disability, and it affects your quality of life, those are usually my indicators for having surgery or surgical correction of a bunion. So there's no true bunion age limit surgically. The important thing to note is that this procedure and the device we're going to talk about, the tools, are basically cleared, FDA cleared for ages 12 and greater. So usually around 12 to 13, 14, the growth plates are starting to close in the toe, and that allows the surgeon to be able to perform this procedure without messing the growth plates up, generally speaking. So that's the answer to that. Is there a bunion so severe that it can't be treated, Doc? Bunions, as you saw the picture before, bunions come in all shapes and sizes. You're just kind of catching a snapshot of it in a certain lifespan. And so I would say no, there is no bunion so severe that it can't be treated. There are some instances where you do have arthritis already built up in a bunion or in the big toe joint. And that typically, we're looking at a different type of procedure and a different pathology. That's typically the end of the road of bunion surgical treatment. But X-rays, that's why X-rays are important in the office to determine if there's any arthritis and a good clinical examination. Another question is, what if I have had bunion surgery in the past? I'm really concerned that my bunion's coming back, and we'll talk about that a little bit. But the key part is that Lapiplasty procedure can be utilized for revision bunion surgery, and that's kind of where this hits home. I've had a few patients that just were not happy with their original bunion correction, and they just wanted a second opinion. They just wanted to see, look, I don't want to. There's no throwing anybody under the bus or anything funky like that. I just want to know, am I going to be okay? And then they just need a pat on the back and whatever, but they need to know that they need to see the X-rays, and really I get my patients to wrap their head around the pathology and what they should be looking at an X-ray if they're shown the X-ray, or what they should be looking at in their foot, so that they know the potential outcomes and expectations after surgery. So as we've learned moving forward, that bunions are a progressive disorder. You saw the display and the lifespan, the natural history of a bunion, and they don't just go away on their own. They typically do get worse. Arthritis, again, like I said, is the end of the road. That is where the joint becomes very stiff, and typically there's no motion whatsoever. And that's usually when the arthritis sets in, and the joint surfaces are so arthritic and stiff that you need a different type of procedure. Bunions do cause hammer toes. They cause bone spurs. They cause pain in the ball of the foot underneath the second toe, and that's one of the more common reasons why people come in. They're not concerned about the aesthetics or the look of the bump per se, but they're starting to notice that their toe is rotating. Their second toe and their third toe are starting to migrate over the great toe or the big toe, and so usually it's another symptom that's driving patients in. The common question is typically revolving around, I don't think I need surgery right now. It's not hurting that bad, but it does bother me on a daily basis. And how can I manage this pain early in the process and try to prevent? So the thought is that we're able to manage some of the symptoms, really. We're not correcting the problem. We're not correcting the root cause of the bunion or hallux valgus deformity, but we're managing the symptoms. And these kind of braces can be worn at nighttime. We also have different types of pads and things to allow people to live on a daily basis with the bunion deformity. Maybe they're not a surgical candidate. Maybe they can't have surgery for whatever reason, or they have to put it off for X number of months. There are options out there to deal or manage with the symptoms. Toe spacers to help realign the toe. Obviously, it's not going to cut the bone itself and put the toe back in position, but it allows a person to wear a shoe comfortably and get through a period of time until they're able to move forward. So moving forward, we want to see what does it look on the inside? What are the surgical treatment options? And let's wrap our head around the previous surgical options and what we're doing now to once and for all, if you will, correct the problem, fix it right the first time, right? So a common misconception is that a bunion is an overgrowth. And bunion, the nomenclature for bunion comes from the word turnip. And so the overgrowth was previously, before X-rays were even around, previously thought to be just a large tumor or turnip, if you will, on the side of the big toe. So the treatment kind of moved forward and said, okay, let's just cut off the turnip or cut it in half and shave it off, and that's where it hurts, right? So let's reduce that big bump and make it smaller, and pain will go away. Well, understanding now the anatomy, the mechanics of the foot, that we really can't do that. That doesn't work. Patients are upset, and that really doesn't fix the problem. So it's a short-term solution, and it's been documented. Research has shown that just doesn't work very well, and we'll get into that a little bit too. So in reality, bunions are a complex deformity. Bunions are caused by an unstable joint or a loose joint in the middle part of the foot that's seen by the bottom arrow here. And so this unstable joint here allows the whole bone or whole metatarsal bone to move out of position. And when that happens, the first metatarsal, or this first bone here, rotates or pivots sideways. And these two little bones here are called sesamoids. So these probably deserve a slide of their own. They're underneath the great toe. Everybody has one or two, typically two. They're the same bones that are in your thumb. If you kind of go ahead and palpate your thumb right at the joint where your thumb bends, not the little joint, but the big joint, you can kind of feel two little bones or bumps there. So these are like little kneecaps I described patients. They kind of get that. We understand what a kneecap looks like. We can touch our kneecap. And so they move with the big toe, and that's what you're putting all of your force through as you walk. Now look at these two little bones here, the sesamoids. They're out of place. They're not underneath the big toe, so they're not here and here, but they're totally rotated way over here. So everything attached to those little bones has totally moved. And let's kind of see what that looks like on an X-ray. So on an X-ray, you can see here, if you see my pointer, everybody see my pointer? So you can see here that these two sesamoid bones, and they're about the size of a blueberry, maybe a little bit smaller, but they're pretty big. And again, we talked about the mechanics of walking. You're putting all of your body weight right here, right through the big toe and straight out. So these two little bones they have to be strong, and they have to be in a good position. If they're not in a good position here, then everything attached to them gets pulled sideways. Okay, so that's how a bunion occurs or forms over time. And so highlighting these two bones, focusing on the first metatarsal and how it's rotated out of position, we'll be able to understand and wrap our heads around how a bunion forms and therefore how to correct it appropriately. So, fact, did you know 87% of all bunions are misaligned in 3 dimensions? Okay, what does that mean? I thought, just conceptualizing bones, okay? So bones are obviously bones, they're big calcium deposit. They're structural tubular objects that attached to them are ligaments and tendons and blood supply and everything else, soft tissue. And the important thing to note is how that bone moves. And some people with flat feet, some people with high arched feet, some people with flexible feet, and there are some people that are just ligamentously or soft tissue looseness or laxity. And so those patients typically have a higher incidence or prevalence of forming bunions. And you add that to the other genetic predispositions, and you add that to the shoe gear, and you add that to being on your feet for 10 hours a day, working, that creates a tight toe box, and that rubs on the side of the toe and causes discomfort. All the while, underneath the skin and the soft tissues, the bones have moved, the foot has widened over time, and these two little bones here, again, the sesamoids or the kneecaps underneath the big toe, have totally flipped out of position. So getting those back into position is the key part. But how do we do that? Okay, well, let's talk about it. So just visualizing here how this bone moves over time in a person with a flat foot or an unstable foot is important. Okay, before I tell you how we do this, that's the secret. You have to wait a little bit. So the analogy, and everyone kind of knows what the Tower of Pisa is, or the Leaning Tower of Pisa. Visually understanding what a bunion is and how it occurs is paramount. So like the Leaning Tower of Pisa, it's unstable foundation here. The bone starts to lean sideways. So we're going to look at the foot in this bone and the big toe, and from the top, the side, and the front. So the top here, you can see it's leaning sideways, right? Okay. So here from the side, you can see that it's not just a 2D problem. So the second dimension of 3D is that this bone here, the first metatarsal, and you can see the sesamoids. Over time, the first metatarsal and the big toe joint, so this is where the bump is on the bunion here and here. You can see as it relates to the second, third, fourth toes, the rest of the foot, it's elevated with a bunion. So see how it overlaps the other toes? So the pressure or force from the ground reactive force pushes up on the big toe. So that's 2Ds. What about the third dimension? That's from the front. This is the most important. And due to the ligament and tendon attachments and how the bone rotates over time, you can see here that just like the tires on a car, they're malaligned here or out of alignment, that whole toe rotates. So you can really appreciate from this view what it looks like, what those tires look like, and maybe, if you're really thinking hard, how we can put it back into position, or if you've already watched the video, which most of you probably have. So we need to put that bone back in position. So it's rotated, so let's unrotate it, and let's make it stay there, okay? So that's the general concept. Well, for a while, let's understand what was done before, because we need to clean up the mess and make sure that we don't do it again. So what we did before was a 2D osteotomy, okay? And the 2D osteotomy started here. Like I said in the very beginning, with the turnip comment, we thought that maybe just shaving off the bump would reduce the pressure in shoes, and it would make it more bearable. Well, first of all, you have to cut open the joint. You have to open the capsule, which creates scar tissue, which creates stiffness, which is the most common complaint after any type of bunion procedure, specifically one that you have to open up the joint. So everyone knows if you've had surgery before, you know what scar tissue feels like. It's dense, it's painful, it's stiff to move. And that's what we're trying to avoid here. So if you do have to open up the joint, then this is what happens here. You open up the joint, you take off a piece of bone, but you're still left with the Leaning Tower of Pisa. So you can see the analogy. We've cut off the portion of the Leaning Tower of Pisa, and then has created a less wide foot or less prominent bump, but it hasn't corrected the root of the problem. So that's obviously this arrow here. Okay, so what we did, we shaved off the bump, we shifted it over by creating an osteotomy, and osteotomy means cut in the bone, and we fixed it. So we put a couple screws in and tightened up the capsule joint in the middle part of the foot. So that's the apex of the foot right here, behind the big toe. So this is the X-ray. You can see, the joint looks all right if you're showing the X-rays and you can see or know what you're looking at. Now that you visualize the sesamoid bones underneath the big toe, you can kind of see where they are, but they still don't look perfect. They're not underneath the toe. The metatarsal here is bowed, and it looks okay. But is it going to last? That's really the question. This is what it kind of looks like clinically. Yeah, it looks okay on the outside, but you don't know what's going on the inside. You don't understand the mechanics, and we didn't get it, and we were kind of crossing our fingers and hoping that this turns out well. Rather than putting lipstick on a pig, let's gosh darn it, if you will, let's fix the problem. Let's go after it. Let's hit a home run. So, fact, research shows that patients are 12 times more likely to have a recurrence if all three planes or 3D deformity is not addressed. So if it's a 2D correction, typically it'll come back. So that's the title of the presentation. Typically is any kind of bunion presentation, or most bunion presentations are, doc, I want my bunion back, because sometimes it just comes back. Most of the time it comes back. 1 in 3 patients are dissatisfied after a 2D osteotomy bunion surgery, 30%. So I have 5 treatment rooms. 2 of them basically are going to be unhappy. That's not a good day. I don't like that kind of day in my clinic. Up to 70% of osteotomy patients experience recurrence over time. So that's just back to the previous comment, what we've shown in our research is that the big toe goes back over, if you will, towards the second toe. The bunion recurs, and it's all because we just didn't do it right the first time. So as this states, let's do it right the first time. And what we're starting to see is that the research supports it. And that's the fun part, is that I don't get to sit here and preach on my 4 patients of experience and how good I am. It's on writings on the wall, if that's the way it goes. Lapoplasty 3D bunion correction works. Let's visualize how this works, how we can do it, and talk about kind of the post-op recovery and perioperative expectations. So this is how it works. Typically we're restoring the normal anatomy, like I said. So you can see how that leaning tower of Pisa is put back in place right underneath the big toe. So this is 3D bunion correction, optimal bunion correction. We're straightening a rotated foot, a rotating metatarsal, and this allows those 2 little bones, the sesamoid bones, to be, the kneecaps, to be placed underneath the big toe, so everything works in a straight line again. So if that makes sense to you, then you get it. This is permanently secured with titanium plates that are patented. They're made for this procedure, and they secure the root of the problem. So again, this is the unstable joint. You can see here that we've made it more stable by securing it with 2 plates and 4 screws. There are some times where we need to use an additional screw or 2, but this, for the most part, is the most common way it's performed. These 2 little bones, you can see through the skin and underneath the bones here that these 2 little sesamoids are back in position. So this is what we need to see. We need to restore normal anatomy. Here you can see on X-ray, this is a top-down view of the foot. So you can see all the toes. You can see how the big toe is creeping on the second toe, and you can notice the large protrusion here and the density of the soft tissue, as well as those 2 little bones I keep referring to, those 2 little sesamoid bones. Now they're back in position. So we've optimized our surgical technique to allow for success and happy patients, etc. And that's what I'm seeing in the office in Phoenix, Arizona. So this is a traditional 2D cut and shift surgery, most common bunion surgery in the world, probably. And you can see on the right how it compares. So let's go back here to the original bunion correction, the unstable, or the bunion X-ray. You can see the unstable joint here where that first metatarsal and big toe are moving. And you can see how shifting it over just doesn't quite make a perfect joint, a very congruous working engine of the big toe. And notice here, it's a nice clean radius, just like this joint, just like the lesser joints, and down the line. So we're restoring normal anatomy and putting the patient and a foot back in appropriate position. There are many different types of bunion procedures. This is another one out there. It's a minimally invasive surgical correction. It's done through small incisions with the hopes or idea that we could stabilize it with some percutaneous screws and wires. This does not work for all bunions. It works for a very small percentage. And the hard part with this surgical correction is it takes precision. This is not for the faint of heart, and it can work in the right hands, but it has not been shown to last as long as the Lapiplasty procedure. Traditional Lapidus was done with larger plates, larger screws, and a different style of bone fixation. Plates and screws vary in shapes and sizes, but you only really need to do what's necessary to allow for bone to heal in an appropriate fashion and well. And what's different about here, you can see the two little sesamoid bones are unrotated or still derotated. You can see here again, they're under the first metatarsal. So that's just kind of showing you again what that normal foot would look like. No bunion complaints, but patient came in for heel pain, and that's what the top of the foot looks like. Again, no bunion pain. The incision typically is on the top of the foot here, a small incision here, and then a small incision here. And so what we're doing is we are putting the big toe joint in appropriate alignment, making those joint surfaces congruous, freely moving. We're not opening up the joint here as traditionally done, which reduces potential for scar tissue and greater range of motion at the big toe, all the while stabilizing an unstable joint in the middle part of the foot. So what we've talked about is kind of fixing the root cause, how we do it by performing 3D bunion correction. We are back on our feet quickly in a walking boot and kind of go over the postoperative course within. We're able to do that by permanently securing that joint. And the neat thing is, as I mentioned, this has been written up many times. There are published clinical articles showing a high success rate, a higher than 95% success rate in, we can see here just some clinical pictures of what a bad bunion looks like before surgery. And what I really want you to hone in on is the big toe, the toenail. You can see the toenail on the left is rotated or cockeyed at about 35, 38 degrees to be precise. And that is a visual cue for how your toe sits. And this is, again, kind of a weight-bearing view. The person's standing, the picture is taken top down. That's the important part. You want to be standing when you're looking at this. But this is basically, for the most part, in individual results, may vary as it says, but in this case, the toenail is parallel to the ground and the rest of the toes. And that's when I know that that's going to be a happy patient, and we've derotated or unrotated the first metatarsal appropriately. These are kind of standard incisions that we use for this procedure, and we're really getting happy patients. And typically right around 12 weeks is when we'll say, look, we're signing off, and we'll see you in 6 months. So let's kind of review that postoperative course here in a second. Just another picture of a happy patient. Again, look at that toenail, great toenail. You can see that there is still a little residual bump, but what's important to know is that that's not really the main problem. The main culprit is pain. The main culprit is what we saw on an X-ray, and that's that unstable joint. So the key with this is, how can we do all that, doc, and still be able to get back to activities, still be able to get back to the dancing and wearing appropriate shoes and hiking and everything that we love to do in Phoenix, all the while still performing surgery? Well, we've done this with patented titanium technology. We've used 2 plates to optimize our fixation, and by using 2 plates, that typically is better than 1, which was has been shown on our bench and lab studies that it is more secure than 1 plate and 1 screw. So what we're seeing is very minimal hardware removal, optimum strength, and that provides us with the ability to weight bear these patients and patients early. So let's talk about the recovery real quick. And this is what most people want to know. They don't want to know, what the surgery looks like on the inside. They don't want to watch the surgical video per se, but they want to know how quickly can I get back to work, and we'll answer some of those questions in a minute. So the typical plan when I'm seeing a patient, I saw 2 today, when I'm talking to a patient about their perioperative expectations and plan after surgery. They're taking notes, we're getting ready, and the most important thing is that you schedule when you are ready. Okay. When patients are ready to schedule, I would like the postoperative plan to be written out so they understand it. So I like patients to just write it out. I want to see and know that we understand together that we're going to ride this ship together and be rowing at the same speed. So typically it's outpatient surgery, which is important. We are allowing patients to weight bear early in a cam boot or walking boot or fracture boot, some people call it. Usually at that first visit, that's kind of the key for me. We want our incisions to heal perfectly. This does vary surgeon to surgeon, but for the most part, I'm allowing patients to walk at a week versus the traditional Lapidus procedure or Lapidus procedure or first tarsometatarsal joint fusion or bunion correction at 6 weeks. So we're really pushing the limits in a good way and still seeing success, which is awesome. So we're allowed to put our weight down in a boot at a week, my first post-op visit. You're in that boot for 6 weeks. I typically have patients coming back at 4 weeks wanting to get into a shoe. They bring the shoe in the office and put it right on the table next to them and say, "Doc, let me into this." And I'm like, come on, wait a second, give me 2 more weeks. And what we're really doing, like, why 6 weeks? Well, we're waiting until, one, the swelling goes down. The swelling goes down when the bones have really started to glue together. We're looking at 70 to 80% of bone fusion before swelling and your body stops reacting to the healing cascade and things. And so swelling starts to go down typically right around that 6 week mark. And that's just what the studies show over time. And we're able to get into a shoe comfortably, a nice sneaker, a nice supportive shoe. And that can allow for just a little bit of swelling as we start to get back into activities. The goal here, especially for our active patients, is to resume most activities, and we'll go into that in a second, what type of activities, Doc. Resume most activities at around 4 months. 4 to 6 is usually what we say is a guesstimate, and most patients fall in between, if not just a little bit early. So again, just to recap, day 1 to 5, we're recovering. We're at these days trying to avoid as many opioids as possible. We typically do a nerve block ahead of time to make sure that our pain is well controlled. We take Tylenol, Advil as needed. It's per surgeon, but for the most part, we're trying to minimize swelling, minimize pain, and that's done by the standard rest, ice, compression, elevation. So dressings are taken off at that first visit, not to be touched or removed until then, typically. Another thing that we are commonly discussing in our conferences and with our patients is trying to reduce complications. And one of the medical complications that can occur is a blood clot. So we do typically advise patients to take aspirin. And again, this is per surgeon. Everybody has their own protocol, but consider taking aspirin as a DVT or blood clot prophylaxis or prevention. So with all those things in mind, first post-op visit, big reveal, we're taking off dressings. Until then, you're just Netflixing on the couch, watching a lot of Netflix, catching up on some old Bachelor shows or whatever, and allowing for that swelling to come down. We are at that first post-op visit taking Xrays. Typically, we will typically allow the patient to start washing their foot, start exercises, and start that big toe moving. So again, we haven't made an incision directly over the big toe most of the time. So we are allowing the patient to start mobilizing that big toe in a non-weight bearing fashion, really just stressing and pushing it up and down and trying to reduce any pain in the big toe. Get ready for a shoe. So we are in our 2.5 week, 3 week mark, and stitches, if they weren't dissolvable, are removed at this time. I usually will institute physical therapy at this point. This allows the patient to get under the wing of a good physical therapist. We do have a team here in Phoenix that does take care of bunions specifically, and getting them into a physical therapist to have eyes 2 times a week on them and begin great toe range of motion, as well as take care of any atrophy that might occur in the calf or leg due to being in the boot and such. So swelling is kind of the most common complaint for a couple months, and that's what I want to stress here, and it's manageable. It's manageable with compression. We do have certain compression sleeves that are worn for about 3 months until the swelling is fully down and you're able to fit into a shoe with very residual swelling. So very little residual swelling. So right around that 6 week mark, We are doing our final X-rays. We are confirming bone healing, that nothing's going wrong, and that we're moving on to we're passing go, if you will. So we're getting into our shoes for sure. We are starting to drive and get out of the boot. And so that's when we're continuing our physical therapy. Usually at that time, we do start allowing light impact exercises, which will be guided by your physical therapist. We will stop our aspirin at that point, typically, again, surgeon specific, but as we're pumping our calf more and getting to a shoe, we're not as worried about a blood clot at that time. So exercises including, as you can see here, light treadmill walking, definitely a stationary bike. Elliptical is kind of my go-to. So 12 weeks, 6 weeks later, so we're at 1, 2, 3 months. And so at this point, start swimming. Let's get into some more supportive shoe gear, maybe consider going out to eat in some high heels or something, and get back to life, if you will. Sometimes we'll talk about orthotics if you do have a concomitant flat foot or other issues, which is a whole separate lecture, but orthotics can be instituted at this time to help manage any other foot and ankle deformity. Right about 4 months is where we start to separate a little bit, and in a good way. That means that you are recovering well. That means that you're released from all restrictions and allowed to go barefoot around the house more comfortably. Return to full activity prescription is usually given, and return to sport. So with that being said, I think there's a couple common questions before we allow it to the audience. When can I expect to return to work? So very common logistical question. I will say from the get out that patients that try to go back to work too soon, and by too soon I mean like the day after surgery, give it a good week. I would give it a good week until you see me. Everything is confirmed, that nothing's gone wrong, that you can be put into a boot, that you can stand for an hour or two, maybe even 3 a day, and without any worry. And I would say that typically is the time frame that I ask my patients to take off of work, and that allows the incision to heal. We don't want to have to go in and chase any infection or have the incision open up or anything crazy like that. So that is typically my go-to answer for that one, 7 to 10 days. Nothing excessive like 6 weeks or anything like that. So that's the whole point of this. When will I be able to drive if my right foot is treated? So studies have been done looking at ankle range of motion after like a big surgery, like an ankle replacement or ankle fracture, and typically it's 3 months for that answer. For this answer, for the right foot, right around 6 to 8 weeks. I want to see a patient come in out of a boot. So usually 8 weeks for me, and it's surgeon to surgeon dependent. If we all had 2 left feet, that'd be great, but half the time this is the problem. So the soft answer is 6 to 8 weeks, and you don't need to go take a driving test or anything like that. Is it possible to have both feet treated at once? It is not my recommendation. One, it's a couple reasons. One, it makes the surgery twice as long, which increases your risk to different things, anesthesia risks and risks to blood clots and all this kind of stuff. 2, it is very, very difficult to be in 2 cam boots at once. And 3, it just extends your recovery. You're not trying to, win any awards. This is your foot. This is your, we all walk on our feet typically, and you want this to go well the first time. So it's not worth rushing. And I would say that about any foot surgery for the most part. So as a reminder, a couple of housekeeping things that, as with any medical treatment, individual results may vary, obviously. There are potential risks. There's a recovery time that needs to be discussed, but some potential risks include infection, blood clots, discomfort from the presence of the implant. If it does become palpable, it might need to be removed, especially people that wear like really, really tight shoes or work boots that press on the implant. Knock on wood, this has not happened to me, but it's possible. Loosening of the implant only if typically there's loss of correction and something goes wrong. And as we discussed before, if something goes wrong means non-union or malunion, the bones didn't heal together, there was an infection, and we had to go back in and clean things out. And this is not common in bunion surgery. If we're picking our patients appropriately and making sure that we do the right procedure, then we can avoid all these catastrophes. So, but to note, if these things occur, that some additional treatments may be needed. So the nice thing about the online presence of Treace Medical and Lapaplasty is that it's super easy to find a doc. If you're in rural Knoxville, if Knoxville's rural, if you're in Maryland, if you are in Florida, you can always find a doc that is close to you and able to perform Lapaplasty procedures. And so just remember, as the states, that this is a device and a technique that is tried and true. So it's patented, and it's the only 3D bunion correction. So we'll go ahead and go over questions. It's just a slide kind of looking at what we talked about in kind of fine detail, the differences between the different types of osteotomies and how they compare to Lapaplasty. So I'll come back to this in a second. And just know your options. Know that, there's a spectrum of bunions. If you have one, you're just kind of somewhere in the spectrum. But know that with Lapaplasty procedure over here on the bright yellow box, it's the only correction that is true to its name. It's the only 3D bunion correction in all planes, and allows for early weight bearing in a cam boot, and reduces scar tissue at the great toe by not having an incision over the great toe most of the time. So I think that's it. Let's kind of sit on this slide for a second and open it up to questions. Kara?
Okay. Well, thank you very much, Dr. McAlister. We really appreciate your time tonight. We've had some questions come in, and I want to encourage people, if you haven't had a chance to ask questions, you can do so by clicking on the question tab in the control bar and type them in. We'll try to get to as many as we can now, and we encourage people to stick around to listen to the answers. We actually I'll start out by answering a question that has come in pretty frequently, and it's to do with insurance. And is the Lapaplasty procedure covered by insurance? And some people also have the question, is it covered by Medicare? And the answer is yes. When the procedure is deemed medically necessary, insurance and Medicare typically cover bunionectomy and joint fusion procedures that utilize the Lapaplasty system. So if your doctor determines that you are a candidate for the Lapaplasty procedure, he or she will reach out to your insurance provider to determine your specific level of coverage. And now I'll go ahead and turn some of these questions over to you, Dr. McAlister. The first one that we had come in is, does having osteoporosis eliminate you as a candidate for this procedure?
So osteoporosis, let me say one question. Let me say something about the insurance. So this is not a experimental device. It is not an experimental implant. It is a patented technology to correct the problem. So it's a known procedure that we're just doing in a different way. So we're still using the same codes, the insurance and all that kind of technical stuff. So it's that being said. So osteoporosis is osteoporosis is weak bone. Okay. So bone is typically very dense. It is a tubular structure that has a thick cortical wall. And so osteoporosis, as it's stated, is a weakening of the bone or soft bone. So I would say with any orthopedic procedure, osteoporosis, I would say maybe severe osteoporosis, would probably be deemed a relative contraindication. So it's not something typically that I ask a patient to get a bone density scan, et cetera. But we can optimize our potential for healing afterwards by first talking to maybe our rheumatologist or endocrinologist and making sure that we're maybe on some right medication. So that could be a conversation with you as a patient, is kind of, have you seen a rheumatologist or endocrinologist, a bone mineral density doctor, if you will. And a bone health clinic is often discussed. And so is not a absolute contraindication.
Okay. Great. We have some more questions. Is the surgery only for those with painful bunions?
So, patient is sitting in front of me. I'm seeing them for something else. Let's just say ankle arthritis or whatever, or Achilles tendonitis maybe. It's a common one today. And I notice the patient has a bunion or protrusion underneath their big toe. And so the patient says, oh, somebody says I had a bunion or whatever. And I ask, does it hurt? Is the next question. And the answer typically is either yes or no. It's not kinda, but it's either yes or no. And so I don't chase unreal symptoms. If a patient has a painful condition that is a bunion, then it is discussed surgical correction, if that makes sense. I don't fix non-painful anything.
Okay. What happens to the second and third toe that has started to move along with the big toe?
Very good question. So what we don't usually depict in most of these pictures, but in a severe case, the big toe, as you remember, the little kneecaps underneath the big toe have shifted. The big toe cantilevers over and touches the second toe. That's kind of the first phase. And then they're kissing, if you will. And then all of a sudden, either A, the second toe gets out of the way and allows the big toe to go under it. So that's called an overlapping second toe, or an underlapping big toe, however you want to look at it. And, so that's a hammer toe that's developed. And sometimes you'll even see the big toe touching the third toe, which is, I would put it in the severe category. And then there are instances where the big toe just pushes over the second toe, and then therefore pushes over the third toe, and that's what you're talking about. And that is common, very common, and we call it kind of molding of the toes. And that's a patient that has a severe bunion. No, they probably don't have a hammer toe, but their toes are all parallel on the same playing field. And that is basically, if you want to think of it like a bunion of the second toe and third toe, it's a dislocated joint, and it is a deformity that we often see with bunions or in conjunction with bunions. So that's something that an X-ray would pick up in fine detail and to discuss with your local doc.
Okay, another question is, will I be able to wear high heels again?
Just common question. And I forgot to say that the second and third toe is fixable. That's kind of the end of that. So high heels is a common question, especially in Scottsdale. And what I need to talk about with the patient is are the high heels for work? Are they necessary? We have not done a study looking at the recurrence of any bunion with a back into high heels, but I will tell you that there probably is uncomfortableness trying to get back, just simple crowding of the toes. But what I've seen is patients in my own practice able to get back into high heels at typically 4 or 5 months. So it's not something that I push right from the get out. I want to see the patient in a wide toe box, like tennis shoe, for the first month to 2 months as everything settles down. And then I allow patients to get back into a high heel.
Okay. So this patient is considering having both feet treated. How long should someone wait to do the second foot after the first foot has been treated?
Very good question. Socratic method would be which foot first. So if it were me, I would do the left foot first, let's just say in January or whatever, and then I'd get through it. I would be in a shoe, and the reason is because I want to be able to drive and get used to this surgical thing, this surgery thing. So obviously, you can, as soon as you're off of narcotics and able to get around in the boot, I allow a person to drive with the right foot if it's the left foot that we operated on. And as the person progresses through their postoperative recovery and they finally get into a shoe and then they're kind of walking normally again, and right around that 4 or 5 months, I say, okay, if they have a bunion on the other side, I would say give yourself a break, wait 2 to 3 months, take some time off, and then dive again into the pool. So yeah, you can do them in the same year. Give yourself a couple months between. That's probably the most common, is 4 to 6 months ish between 2 feet. But it's patient specific and insurance specific, and there's a lot of like variables thrown into it. But I tell my patients to at least take a break.
Well, speaking of driving and returning to driving, I know you answered this question earlier, but is there a difference in the time point that someone can return to driving if they get the left foot treated versus the right foot? Can they drive faster with the left foot than the right foot?
Yeah. So if I did the left foot and I see them at a week and they are, it's really a matter of whether they want to drive, but let's just assume they have to drive for work. So if they see me at 7 to 10 days, we put them in a boot. They're not on narcotics. They don't have to drive over an hour, let's say, or a long drive, and they have assistance. So typically, if give them a handicap parking sticker, they can park close, and they don't have to walk a mile to get to the office. Then that's kind of the perfect scenario where I say, okay, go for it. Be careful. Drive with your right foot, and be safe, and get as much assistance from work as possible to park as close as possible. So if that answers the question.
Okay. This person has actually had a traditional 2D surgery 11 months ago, and she's being told that her body may be rejecting the hardware. She is not pain-free 11 months on. She is asking, would her body reject this 3D product if this is truly an issue with her body rejecting hardware in general?
Okay, so there's a lot that can go into this answer. This is almost like a board exam. Yeah, if you have a patient has painful or loosening hardware, or the questions to be asked, really, one, first of all, before asking any questions, I would need to see the patient in front of me and see X-rays. And there's a couple of things. One, is it infection? Two, is the bone healed? Three, what type of metal was used, or what type of screw? And and the last one would be the allergy. That's usually kind of low on the totem pole. We do have serum or blood tests to make sure that you are or not allergic to a metal. Typically, the titanium that we use, the anodized titanium, especially with Lapiplasty, has a very, 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 and I'll put another very in there, low chance of rejection. It's pretty much the lowest besides real bone, and like compared to stainless steel, if you will, rejection or an allergy. So we check the allergy. First and foremost, we go up the list, and that would be with infection. And so X-rays to make sure that the bone's finally healed, get a CT scan to make sure that the bone's finally healed, get blood tests to make sure that there's not an underlying infection. So you kind of want to rule all these things out before we dive into a muddy mess in the OR. We want to know exactly what we're expecting. And last on the list would be the allergy. That's just usually not common. Yeah, there's appropriate workup that needs to be done before going back in. So just my 2 cents.
Okay. This person has a bunion, and she was actually diagnosed with an MTP sprain of the big toe, and it's made her toe hurt even more. So she's wondering, can the sprain have worsened the bunion?
Chicken or the egg? So can a sprain worsen the bunion? Yes, is the basic answer. If there was, as you've seen, like in the images and the X-rays, everything's out of place in the bunion. The bones are shifted around, and that only occurs if ligaments are stretched out, and a sprain typically is a torn ligament. So if there is a torn ligament in the big toe, could the bunion worsen? Yes, is the basic answer. I'd probably want to see an MRI, make sure that, what ligaments are torn and things like that. And probably, go through some conservative treatment prior to jumping into like an elective, non-traumatic foot scenario. So a little bit of a workup, but nothing totally out of the ordinary. And bunions can be caused by trauma, kind of in just a small percentage on the pie puzzle or the pie chart. A small percentage of cases, but not totally unheard of. So I'd have to kind of sit with you and talk about that pathology a little bit more and how that happened.
Okay. Can hammer toes be fixed at the same time that you're having a Lapiplasty procedure?
Good question. So one of the most common procedures we perform in orthopedics, besides a hip and knee replacement, is hammer toe correction, typically because most people have 8 hammer toes. And yes is the nuts and bolts of it. It can be done in many, many, many different ways. That's, again, a whole nother hour or 3 webinar. And so that can be discussed with your local doc. And yes, they can be corrected at the same time with a myriad of different techniques and things. It just kind of depends on how bad it is. So this isn't something that we usually stage or do in 2 separate procedures. It's something that can be easily done at the same time as your bunion correction. Yep.
Do the metal plates that are used in the Lapiplasty procedure limit my mobility postoperatively?
Okay, good question. So again, kind of highlighting back to the root of the problem, and here, I guess let's put it here. So the picture on the left, the unstable foundation, remember, is kind of in the middle part of the foot. So those joints at the apex or the arch of the foot, one of them is unstable. And so what we're doing again is putting that bone back in position where it should be, fixing it or affixing it with 2 small plates that are very, very thin. And we don't really want that joint to move anymore, if you think about it like that. We are trying to allow a joint that is becoming more and more stiff, the big toe joint. I want that joint to move. I want that joint to become more normal than it is now. And the joint that is in the middle part of the foot, that unstable joint, does not impede or limit my function of the foot and allows more normal alignment and foot function properly aligned. So I guess no is the answer to the question.
Okay. Can you fix a talar bunion? And maybe somebody needs to have that defined for them as a listener. Can you fix a talar bunion at the same time as doing a Lapiplasty procedure?
So a bunionectomy, bunion correction, or Lapiplasty procedure typically takes about, let's just say, between 45 minutes to an hour and a half, and like in the OR. So wheels in, wheels out, and very surgeon dependent. But in my OR, let's just say a little over an hour. And there are some things that I just won't do at the same time, and that's not one of them. So anything basically in the forefoot, and we call the forefoot the toes area. So hammer toes, crossover toes, tailor's bunions, and a tailor's bunion is a mini bunion, bunionette, baby bunion. These are all kind of slang terms, but it's around the 5th toe. So imagine a bunion behind your 5th toe, not your big toe. And same kind of concept, just different part of the foot. We don't typically treat it exactly the same, but it is more of a protuberance and and prominence than it is a rotation of the bone, like a big toe joint is. So yes is the answer, and hammer toes included, as alluded to before, answered before, and some other metatarsal bone cuts or osteotomies too. But the main purpose of fixing the forefoot all kind of at the same time is, one, you can see it in real time in one surgery. If we're doing other surgical procedures in the back part of the foot, it should be probably in a staged fashion to allow for the big toe to heal first, and then move on with the back part of the foot or the ankle.
Is the Lapiplasty procedure an outpatient procedure, and what type of anesthesia is used?
Good question. So I would say 98% of what I do is outpatient, this being one of them. The neat thing about foot and ankle surgery is that most of it can be done under general anesthesia. And so you're going asleep. You are given the risks, benefits, and complications of general anesthesia by the anesthesiologist. This is typically done at a surgery center or small OR style hospital, and is again you arrive an hour and a half beforehand. We are doing a nerve block beforehand so that you're numb for about a day, and that allows you to be off of those pain meds very, very quickly and back onto just Tylenol or nothing, ice and compression or your friend. And then as that hour's procedure goes by, you're getting general anesthesia, and that way it's a more efficient operating room. I'm able to get done what I need to do in a timely manner and allow you to get out of there safely as a patient, and just reduces the risk of everything, infection, blah, blah, blah. And so, yes, general anesthesia, outpatient, always. And typically, when I give a patient a call a couple of days later, they're happy and their nerve medicine has worn off, but they were prepared for it. And it's all about expectations, as we're discussing here, and kind of knowing what you're getting into. So that's a good question.
Is yoga doable after the surgery with all the foot flexibility and bending?
Yes, it's actually, I would say, one of the better exercises or activities that I promote afterwards, because that's what I want you to do. I mean, that's your own physical therapy. That's the downward dogs, and I don't do a lot of yoga, but that's the only one I know. And I know that planks and downward dogs and everything else promotes flexibility, and that's what we're doing. It appears as though we're securing or removing motion from a part of the foot, but in essence, we are actually promoting a more important joint, the big toe joint. So I'm all about the yoga. Keep doing yoga.
Can I be a candidate for the Lapiplasty procedure if I have arthritis?
Good question. So that kind of is a question for the clinical examination, and how I determine if a patient has arthritis without looking at the X-rays is I was describing to a couple patients today. So imagine a tooth, and if a tooth has a cavity and you bite down, that tooth is very painful, right? And when water gets in or anything, and it hurts when you bite down, and that's why we fill the cavity. Well, if I'm able to push my big toe or your big toe down on the metatarsal, so I'm pushing in the big toe and moving it up and down, putting it through range of motion. We call that a grind test. And so the grind test is important to me, because if the patient has a bunion and I put their toe through range of motion, I'm like, does it hurt? Up and down, not the bump, not touching the bump, but I'm putting the toe through range of motion. And what I'm imagining is those two cartilaginous or cartilage surfaces gliding. And if it's a smooth surface and I'm pushing it down one on top of the other, no pain, that to me is a patient that does not have arthritis. And so if a patient did have pain with that, then typically I will lean the patient more towards a big toe fusion, which is kind of the end of the road or end all be all for big toe arthritis with or without a bunion. and that's where we hook the big toe together, which in and of itself is a successful procedure. And the Lapaplasty technique and the more so the plates and things can be used for that too. But it's really about patient selection. That's important here, and that's why we train surgeons in a specific manner, not only to do the procedure, but choose the procedure and the patient for the procedure. So the answer to the question is, if you have big toe arthritis, typically my answer is no Lapaplasty, because you would do better as a patient. This isn't a catch-all procedure. You would do better as a patient with a big toe fusion. So, and that's also visualized on X-rays in the office. So there's a couple of things that need to be done to look at the big toe, but by and large, if you have arthritis in the big toe with a positive grind test, then typically I would say a big toe fusion.
Okay. Okay. Well, we're starting to kind of wind down here. I have a few more questions, though.
Sure. Go for it.
How does the Lapaplasty procedure compare to a minimally invasive procedure?
Very good question. So I've tried it all. I've done minimally invasive procedures. I've done open procedures. I've done the head procedures, as you can see on the left here, the traditional osteotomy surgery, the most common type of bunion procedure done. And I've done Lapaplasty. And what, again, not to sound cheesy, but what has changed my vision, my outlook, my understanding of the pathology, what we're dealing with, every foot and ankle surgeon hopefully is dealing with on a day in and day out clinic day, is what a bunion is, how to fix it, and there are some very few instances where a minimally invasive procedure can do okay, but for a active patient that does not want the bunion to come back, my most successful and what the research is showing is to realign the big toe. And that is very difficult to do in the minimally invasive procedure, not impossible, but very difficult to do in an untrained operating room. So that's kind of my caveat and my disclaimer or whatever. Some patients do well. I think that it doesn't truly restore the anatomic ability of the foot to function. And so that's what I got to say about that.
I have another comparison question. How does the Lapaplasty procedure compare to a Lapidus procedure?
Okay. So as you can see, Lapaplasty is a play on words. It's a procedure that is it is a different technique to perform the same procedure. So it is a tool, as I described before. We're still using the same codes. We're still welding a joint together, but we've figured out how to do it better. Okay, we know how to drive a car. We know how to do electric cars, but if you will, the car with the insignia of a T or a Tesla, they, if you will, can do it better. And so what we've figured out is we already know how to do a Lapidus. That's just hooking a joint together. We can do that with plates and screws. We can do that with Xrays. We can do that with anything. But we need to know how to do it perfectly. We need to know how to do it with low recurrence. And if you don't understand how the problem occurred, then you don't know how to fix it. So, going through my residency training and things, we did a fair amount of bunions, and most of the time, I would say 70% of the time, we did the procedure on the left. 30% of the time, we did the procedure on the right. And having a basic understanding of how a bunion occurs and how to prevent it is important. And what we've started to understand and really grasped our hands around is, hey, we can make this near perfect with a very low recurrence rate if we do it this way. And so this tool, Lapaplasty, allows us to perform a Lapidus way easier, faster, and all the good things that we've talked about tonight, and with low recurrence. So it is a a new spin on a old procedure, if you will.
Okay, just a couple more questions. Is there a bunion too extreme to be treated with Lapiplasty?
Bunion too extreme. So basic answer is no. So I've treated in my Phoenix clinic, we call them intermetatarsal angles, or let's just call it mild, moderate, severe. I've treated the full gamut, mild, moderate, and severe bunions. Sometimes there are some ancillary procedures that need to be done to help fixate or realign a certain other bone in the great toe, like the proximal phalanx or the big bone in the big toe. Sometimes that's necessary to help us surgeons kind of realign all those ligaments and tendons. But I would say no, there's no bunion too severe. Otherwise we'd be chopping off toes all the time, but it's fixable. It just has to be put in the right hands to know how to do it correctly.
Okay. All right, last question of the evening. When can I return to sports and all activities after the Lapiplasty procedure?
So as we went through the post-op course, kind of highlighting, let's back that up. I do Ironmans and triathlons and things like that. I would not recommend doing a sprint triathlon until probably right around that, maybe 7 months, if you're super healthy and heal perfectly. So it's stepwise, and that's the understanding and expectation should be discussed. That, hey, we're not going to jump back into this. We don't want anything to break, recur, etc. And you have to do it the right way the first time.
Okay. All right. Well, as we begin to wrap up now, if you think of some question that you wish you'd asked and you didn't have time to do so, you can feel free to shoot us an email at patientinfo@treace.net or reply to one of the emails you've received from us. We're happy to facilitate getting any other questions that you have answered. And you can also learn more or find a locally trained doctor by visiting our patient website, www.alignmytoe.com. And as a follow-up, we will be emailing all the registrants that attended or signed up an archived webinar link. So be on the lookout for that from us in the next couple of days. We hope you found the information presented tonight helpful. We really appreciate you, Dr. McAlister, taking time out of your evening to join us, and we hope everyone has a nice evening.
No problem. Thanks, Kara. Thanks, Treace team, and have a good night, guys.